Hello, good evening. Today we are going to discuss together colorectal surgery, eMRCS question bank. As every time, everyone will start a question and answer, and we will discuss and clear the answer and the rest of answers. Why not? And if any related questions as well. Today we are going to discuss a topic. Sometimes it's a little bit not easy for non-surgeons, but I just want to put in mind today some points during reading your question. The first thing, I just want you to put in your mind the age of the patient. In most scenarios today, he will tell you the age of the patient. So just put in your mind during reading, what is the age of this patient? Is his young age? So you are thinking about certain disease, or old age, so you are thinking about certain disease. So young age, you are think about polyp, about inflammatory bowel disease. This is related to the colon or appendix, something like this. Old age, you are thinking about cancer. You are thinking about diverticular disease. Okay. Second point, I want you to concentrate about the bleeding. If there is any bleeding, is it bright bleeding or fresh bleeding or dark blood? Dark blood associated with old blood, which would be mostly diverticular disease, which will cause dark blood and sometimes upper GI bleeding. Fresh blood will be something like angiodysplasia, fissure in ano, or bleeding ulcer in the rectum. Okay. The other thing I want you to concentrate is the bleeding is painful or painless? Okay, so this is important point. Think also, like I say in all previous MCQs, think about what is the definite management, or what is the next step, what is the most common, and what is the earliest complication or the first step you will take. So just concentrate about every word in this scenario, because eMRCS is very concise about this, and every word and every sentence is related to the answer directly. Okay?
Yes.
So let's start with Dr. Dafer, followed by Dr. Nuran. Dr. Abu Yazid will join us soon. Yes, as soon he's ready, and Dr. Ahmad Awida, if ready, also can participate with us. And any other one who is ready and has no noise background can just raise hand, and I'll open mic for him so he can participate with us. Let's go for the first question for our discussion today. Dr. Dafer and Dr. Nuran. Okay.
Started. What is the early complication that occurred follow construction of the ileostomy? Prolapse, retraction, necrosis, parasternal hernia, and dermatitis. So the earliest complication after reconstruction, it's necrosis. C.
Okay. Anyone has different answer? Okay, exactly. Ischemia. No, Dr. Nuran. You can open mic, Dr. Nuran. Ischemia is the first thing you afraid after any ileostomy or colostomy. The most important thing for surgeon, he start to check his colostomy or ileostomy site and make sure that it is not ischemic stump. And this is most important thing to follow up the patient after a few hours after surgery. Dermatitis is the most common complication. So here is the question can come with two scenarios. What is the most common complication? Dermatitis. What is the earliest complication you're afraid of is necrosis or ischemic necrosis. Okay, Dr. Nuran. Next question. I already unmuted you, Dr. Nuran. You can go. No.
Can you hear me?
Okay.
Okay.
Yes.
A 22-year-old man has a history. A 22-year-old man has a long history of ulcerative colitis. His symptoms are well controlled with steroids. However, attempts at steroid weaning and use of steroid-sparing drugs have repeatedly failed. He wishes to avoid a permanent stoma. Which of the following is the best operative option? A. Panproctocolectomy and endoileostomy. B. Abdominoperineal excision of the colon and rectum and colostomy. C. Abdominoperineal excision of the colon and rectum and construction of an ilioanal pouch. D. Panproctocolectomy and construction of an ilioanal pouch. E. Subtotal colectomy and construction of an ilioanal pouch. Okay, he wants to avoid a stoma, so I'm gonna eliminate A and
exactly.
And colostomy B.
Okay.
Ilioanal pouch. Okay. Abdominoperineal excision of the colon and rectum and panproctocolectomy construction ilioanal. I think B.
So your answer is
B.
D. Yes.
Yeah.
Yes, D, exactly. Okay. So like you, I like your thinking with loud voices. As we are going to do, he is a young patient with ulcerative colitis and unresponsive for steroid or steroid-sparing drug, and he can't continue in his steroids for life. So the patient wants to avoid a stoma. Okay, this operation will be elective for a young patient. Let's go for this. Panproctocolectomy and endoileostomy, it is an elective operation, and the patient wishes to avoid a stoma, so it is not logic to do it for him. The other thing, abdominoperineal and abdominoperineal operation is for cancers only. We don't do abdominoperineal for any disease of the anal or the rectum or any disease of the GIT, the anal diseases, except for cancer only abdominoperineal. So B and C will not be excluded. We'll go for G and E, which will be panproctocolectomy with ilioanal pouch and subtotal colectomy and construction of ilioanal pouch. Subtotal, we don't do some subtotal colectomy for ulcerative colitis because the patient will be widespread through the colon, so you can do some and some. Okay, and how you do subtotal colectomy, and there is stump of the rectum and you do an ilioanal pouch, even it is unlogic treatment, because subtotal colectomy, you remove all the right and transverse and maybe some of the left, and you will reserve the sigmoid as an example. So how you can do ileoanal pouch, so it is unlogic answer. So our answer is panproctocolectomy with construction of an ileoanal pouch. Okay.
Okay. Just I notify some things. The
Yes.
panproctocolectomy, it is elective case. Subtotal colectomy in emergency case.
Exactly. If the patient is in emergency condition, we will do subtotal colectomy. Some subtotal colectomy, sometimes ileostomy, and
Yes.
we will not do anastomosis in, and we will face some scenarios where the patient is not improving and the patient in a critical condition, or the patient is unstable to do ileoanal pouch. So you will go for subtotal colectomy, but subtotal colectomy with ileoanal pouch, something unlogic.
Logically, yeah.
Thank you, Dr. Doffer.
Thank you for you.
Okay, next question. Dr. Abu Yazid, when you are ready, just raise hand, please. Okay, Dr. Doffer, go.
Yes. A 56 years old presented with the episode of the pruritus ani and a bright red rectal bleeding. On examination, there is a mass in the anorectal region, and biopsy confirms squamous cell carcinoma, the most likely cause carcinoma, rectal carcinoma, soft tissue sarcoma, retrorectal cyst, pilonidal disease. So it is anal carcinoma.
Exactly. Okay, yes. So here is our scenario. Is a patient with pruritus ani with bright rectal bleeding. In examination, take care that the patient is about 56 years old. So we just can put two scenarios, maybe cancer, maybe fissure in ano, maybe hemorrhoid.
Yeah.
These three diseases can cause bleeding, hemorrhoid, fissure in ano, and rectal cancer. So in examination, in all these rectal regions, a biopsy confirms squamous cell carcinoma, and we all know that
the anal carcinoma,
squamous anal canal, yes, is a squamous lining.
Below the dentate line, above
below the dentate line is stratified squamous epithelium.
Yes.
Okay, so squamous cell cancer will be the most common. So anal cancer will be squamous cell cancer. Okay, so it's just an easy scenario. You just want to tell you this is a fissure in ano up, and I think this is hemorrhoids in the below. Okay, next question, Dr. Nuran. Okay.
A 25-year-old man complains of passing painless bright red blood rectally. It has been occurring over the past week and tends to occur post-defecation. He also suffers from pruritus ani. The underlying cause is likely to be amenable by treatment from which of the following modalities? Okay, first, the diagnosis is fissure in ano, pruritus ani, and no, but it's painless. It's painless, so it's hemorrhoids. It's painless, so it's hemorrhoids.
Exactly.
Right, Chad?
Yes.
Okay, so A, topical GTN, B, topical diltiazem, C, rubber band ligation, D, injection sclerotherapy, E, lateral internal sphincterotomy. I'm between rubber band ligation and injection sclerotherapy.
Yes.
I'll
Perfect.
go with D, injection sclerotherapy.
It's a good trial, but
before that,
in hemorrhoids, yes, we go for rubber band ligation, and it gives good result as hemorrhoidectomy as well, especially when it is not prolapsed. It is not severe from first or second degree You excluded topical GTN and diltiazem and lateral sphincterotomy because this is for fissure in anus, and you just put yourself between two choices, rubber band ligation and injection sclerotherapy, and this is very good thinking in the exam. So, but here it is rubber band ligation and gives you the same results like surgery. Okay.
Okay.
Okay. So it is painless bleeding. Painless bleeding, go away from any fissure in anus, and we'll go for his young age. So we'll go for hemorrhoid, and we'll think about treatment of hemorrhoid. Treatment of hemorrhoid, if it is a first or second degree, we'll go for band ligation. If it is prolapsed full thickness, we go for surgical hemorrhoidectomy. Okay.
Yes.
Dr. Abu Yazid is ready, so he can go with us. Okay. Unmuted. Go for next question.
74-year-old gentleman present with an obstruction carcinoma of splenic flexure. Attempt at a placement of colonic stent have failed, which have the operative option listed below offers the best solution of this problem. Subtotal colectomy, extended right, standard left hemicolectomy, or transverse colectomy. That's B, extended right hemicolectomy.
Exactly. Okay, and if you want to continue the operation, what will you do? If you want to add anything.
Stoma, you mean?
Yes.
Endoleostomy?
Yes, you'll do endoleostomy for further
for defunctioning, just
revision.
For defunctioning.
No,
yes,
no, excuse me.
Okay.
For right hemicolectomy, included.
You can go direct for anastomosis. Okay.
Even
this depends.
Splenectomy, even the splenic flexure. After that, we can judge.
The only thing is that you can't make the idea here that you can't make colocolic anastomosis or coloanal anastomosis. Okay, with obstruction, the ileocecal valve just protect against backflow of air or any distension at the ileocecal valve. When you are going to do a right hemicolectomy or extended right hemicolectomy, you will remove at least 10 centimeters from the ileum, so it is easy to do ileocolic anastomosis or ileoanal anastomosis. Yes, but if you are going to do a left hemicolectomy for obstructed or a sigmoidectomy for obstructed case, you are going to do a Hartmann procedure. Okay. Thanks, yes. Dr. Duffer, for good notice. Yes, I just confused with this. Exactly, we go direct for anastomosis.
Yes.
Okay. Any obstructed patient, you can't do the definite treatment, and you'll go for removal on the left or sigmoid. You'll go for removal of the mass and make a Hartmann till the definite treatment. Except for the right-sided hemicolectomy, you will go for direct anastomosis. You can go for direct anastomosis if the patient is not septic. Okay. Next question. Who's there? Dr. Duffer.
Yes. A 45 years old female is diagnosed with having carcinoma of the cecum. She undergoes CT scan, which show a tumor invaded the muscular propria and the some regional lymph node. What is the most appropriate initial treatment? Right hemicolectomy, external beam radiotherapy, chemotherapy, combination of the long chemotherapy course of the chemoradiotherapy refer for palliative surgery, I choose the right hemicolectomy.
Yes.
Because the lymph node it is related to the arterial supply, and during the right hemicolectomy, we collect the right colonic artery and remove all the nodes. Yes.
Okay. So you choose right hemicolectomy. So under the CT, you chose tumor invading the muscularis propria with some regional lymphadenopathy with appropriate initial treatment. We'll go for right hemicolectomy. Just a second, please.
Okay.
Sorry, excuse me. Okay. So this is a 45 female diagnosed having carcinoma of cecum, Chandrico City, chose tumor invading muscularis propria with some regional lymphadenopathy, the most appropriate. We'll go for right hemicolectomy. Okay, so tumors of the cecum on the right side, even there is regional lymphadenopathy, we always go for excision of the tumor, maybe removal of the lymph nodes or not according to the staging. Okay, also the chemotherapy is dependent on the final histology. Okay, next question, Dr. Nuran.
A 65-year-old lady is admitted with large bowel obstruction. On investigation with CT, she is found to have a tumor of the mid-rectum with no evidence of metastatic disease. What is the most appropriate course of action? A. Formation of a loop colostomy. B. Laparotomy and Hartmann's procedure. C. Panproctocolectomy and end ileostomy. B. Low anterior resection and covering loop ileostomy. E. Low anterior resection and end colostomy. 65. Mid-rectum. Low anterior resection and ileostomy. Is this the definitive treatment or like
She's obstructed. She's obstructed patient. She will not go for the definite treatment now.
So
okay,
we're
so
thinking about
she's
loop colostomy.
Loop colostomy. Okay, let's think about, yes, she's right, loop colostomy, but let's think how we are approaching the answer like this of this patient. Okay.
Well, first we need to divert the intestinal contents away from the surgical side, and so we would start with
where is the cancer here? Okay, now we have a patient obstructed, so it is an old patient and she is obstructed. So we'll see what is the obstruction. Is it on the right side or in the left side or in the rectum? Okay.
Mid-rectum.
Here we have in the mid-rectum with no evidence of metastatic disease. Okay, the most appropriate treatment. For continuation, what we said before, okay, loop colostomy is the right? What we said before. On the right side, even the patient is obstructed. If obstructed, you'll go for right hemicolectomy or extended right hemicolectomy, and you'll go direct for anastomosis. Okay? For patient with left colon or sigmoid, you can go for removal of the mass or the tumor with end colostomy and Hartmann pouch. Okay? You
Yes.
can't do direct anastomosis because in obstructed cases on the left side, there is high risk of failure of the anastomosis. Okay, and I said when there is colonic obstruction, you can't anastomose the obstructed colon. Okay, the third point is the rectal cancer. Rectum is an extraperitoneal, mostly an extraperitoneal structure. You can't go for definite treatment for the rectum cancer or rectal mass without complete diagnosis and staging by MRI. Okay, rectum, so we have three categories, right, left, and rectum in a certain category. You can't go for rectal operation without full staging with MRI and full all the strategies of staging of this tumor. Then you go and choose your definite treatment. So as there is, we will deal it with like it is left-sided obstruction. We will do, but we will go for a loop colostomy in continuation, and just go for definite to relieve the obstruction. Go for definite definite diagnosis with MRI, and then we go for the definite surgery. Okay. It's clear the difference between the three situations, or again?
The right side.
Right, go direct for.
Can explain
Sorry.
I can explain in the shortly by imaging, by draw the imaging. Everyone imaging
Okay.
between appendix and the. Okay, continue. Or
okay, I can do something here. Just a minute. Okay, I write here. We have three categories: right-sided, left plus sigmoid. Okay. Rectum. We will guess, or we will consider all these obstructed. Okay. On the right side, you can go direct for, this is obstructed, you can go direct for removal of the mass with right hemicolectomy or extended right hemicolectomy. Okay. And then go direct for anastomosis. Why is the idea we do the anastomosis here? Okay, I have this is the colon, here is the obstruction, and here is the distension. Okay, so all this is distended till we here ileocecal valve can just obstruct the distension of the colon, or at least will not be distended as much as the colon. Okay, so when I go for right or extended right hemicolectomy, okay, and this is so distended, I remove all the distended bowel, and what will end for me? I'll found this. I found this one like this, and I have the ileum here. So I can anastomose the ileum direct with the colon. Okay. On the left side, what I'll do, I remove the obstructing tumor, and then go for end colostomy. Why I go for this? Because I have, again, this one, and I have the obstruction is here, and I have all this distended. Okay, so when I remove this, I'll find a stump like this and a distended colon like this. I can't do an anastomosis between this and this. What I'll do, I'll go for end colostomy and then go for the definite anastomosis after subside of the acute condition. Okay.
So in the left side, I do an end ileostomy and end colostomy.
End colostomy, no, not end ileostomy. I just removed left hemicolectomy or sigmoidectomy. So I still have part of the colon, the ascending colon and the transverse colon are still I have. So I can't. I can use the colon to do a colostomy. Why ileostomy? Is it clear? Clear? Or I explain it.
I have a stump right?
In the left side or the sigmoid here, I'll just remove left hemicolectomy. So I already have part of the colon, so I'll go for colostomy. Why ileostomy here? I already have this. This is all still. I still have all of this. Okay.
Yes. And the stump and the rectal stump.
Yeah, I'll do Hartmann.
Okay.
I'll do Hartmann. Okay. Now in the rectum, we go for the rectum. Rectum is mostly, okay, the upper part is intraperitoneal and most of it is extraperitoneal structure. In extraperitoneal structure, I have to diagnose mostly extraperitoneal part of the rectum. If I want to definite diagnose and definite staging, I have to go for MRI. So if I have a mass obstruction, in the rectum, I can't go for removal of the mass like I do in the right and left. But what I'll do, I'll just make a loop colostomy. So I have all this distended, okay, because of mass here in the rectum. Okay, in the left side, I remove, okay, I remove in the left side, I remove and then make an end colostomy. But in the rectum, I can't do any operation in the rectum without definite diagnosis. But the patient is obstructed. What I'll do, I'll go for loop colostomy. Okay, I'll extrusize part of the rectum, even here or here or just any part. Mostly we do it in the transverse. Okay, I'll make a loop colostomy on the anterior abdominal wall for relief of obstruction. Okay, then I'll go for definite MRI diagnosis and I'll go for the definite strategy for the full diagnosis and then go for my definite treatment. Is it clear?
Yes, thank you so much.
Dr. Abu Yazid, تفضل. Right, where are you? Is it clear? Dr. Dafur, do you want to add?
Yes, I sent the picture. It is simple. I will do it. And after record, I mentioned it is in the simplest way. because the time.
Okay.
So treatment is the same in right and left with sigmoid, obstructed or not. But in rectum, it dependent.
No, I'm talking
Right.
about obstructed now. I'm talking about obstructed.
Okay.
I'm talking about obstructed. Okay.
So
I have an
right side,
obstruction and the mass on the right side. I remove the mass and make anastomosis direct.
Mhm.
Okay.
so if not
I have
obstructed,
the same as in obstructed, I did the anastomosis. So if it's not obstructed, I'll do the anastomosis as well.
right. So the
Okay.
right and left, the
This
same
is on
treatment,
the right.
but the rectum is
This is
depending,
on
is
the right.
obstructed or not. Okay.
In the left, obstructed. In the left, if obstructed, I will go for removal
Hartman.
and colostomy
تمام.
and Hartman. Okay.
Okay.
Okay. On the left, I can't do direct anastomosis because the rectum, because the colon is distended. I can't anastomose a part of distended colon with a part of non-distended colon.
Okay.
Is it clear?
تمام.
In the rectum, but I already removed the mass. Okay. In the rectum, if I want to remove the mass, I should previously do an MRI and make my full investigation and my full staging before going to removal of the rectal mass. To know my limits, what is the level and what is the grading and what is the structures invaded and everything before I go to the rectum. If I didn't do that, there is a high failure rate. So in the rectum, I can't remove the mass. So the patient obstructed, what will I do? I'll just do loop colostomy to relieve the obstruction and go for more investigations like MRI and others, and PET scan and CT chest and abdomen and pelvis. And after my full diagnosis, I'll go for my definite treatment. So I remove the mass in the right and left and sigmoid, but I can't remove the mass in the rectum. And I'll go for colostomy, loop colostomy, till the final diagnosis
Type.
and the final treatment.
If the patient have a mass left side of sigmoid, okay, and there is no obstruction,
take your time in your staging and go for the definite treatment.
okay, different treatment.
You have a mass and he is not obstructed. Go for a biopsy from the mass, go for CT, go for full CT chest and abdomen and pelvis, do your tumor markers, do your staging investigation, do everything, and then go for the definite treatment, which will mostly be
remove
with
anastomosis
anastomosis.
defunction, صح?
Remove and anastomosis direct على طول.
Okay.
If you have no obstruction, no problem with no
تمام.
obstruction. The problem was the obstruction. We are dealing with a critical patient. Okay. Dr. Nuran. Dr. Nuran, yes.
I just wanted to ask about the patient who had splenic flexure tumor. Is this why
Yes.
we did extended right hemicolectomy so we can
Extended
do
right.
a primary?
So we can do a primary anastomosis.
Okay. So we
You can
do
anastomose the part of the ileum. The part of the ileum you can anastomose it. You just think about, if I remove the mass, is the two ends of the GIT, I can coapt together and I make anastomosis, or I can't. In the case of right or extended right, I have the ileum and I have the non-dilated part of the, because I remove the dilated part of the colon, and I have the non-dilated part of the colon, so I can anastomose. But if it is in the left or a sigmoid, so the proximal part is massively dilated or dilated, and the distal part is not dilated. So I removed the mass. So now I have two calibers, different calibers. And the proximal part was obstructed, maybe it was a little bit ischemic from distension. It is not healthy enough to do the anastomosis with a high failure rate of the anastomosis if I did it. In case of the rectum, no, I can't remove the mass. I can't remove the mass, so I'll go for defunctioning, or I'll go for loop colostomy for relief of obstruction, and then start to complete my investigations.
Okay.
Okay.
Clear. Thank you so much.
I hope this.
Sure.
It's for obstruction. Yes.
For obstruction, yes.
Okay.
Sure.
Yes. Okay. Next question. This is very important point, and I took my time in it because we will face it many times. Many scenarios we will face it. Okay. So next question. Doctor. Start again by Dr. Dafer, Dr. Nuran, and Dr. Ulyazmi.
78 years old lady from the nursing home is admitted with the 24-hour history of absolute constipation and abdominal pain. On examination, she has distended abdomen with the soft mass in her left iliac fossa, and X-ray performed, which show large dilated loop. Bowel in the left iliac fossa with contain fluid level. What is the most likely diagnosis? So it is in the left iliac, celiac valvulus, sigmoid valvulus, incarcerated hernia, diverticular structure, and malignant chronic structure. It is sigmoid valvulus.
Exactly. This scenario, this old patient, patient with absolute constipation and long history of constipation, soft mass on the left side with fluid level, and she is, I think she will be obstructed. And with this fluid level, so cecal valvulus, no, it does not happen. Sigmoid valvulus, yes. Incarcerated femoral hernia, no. Okay. Diverticular structure, no, it will not give a mass. Even the femoral hernia will not give us a mass, and there will be groin pain and maybe a mass in the groin. Malignant chronic structure will not give a very big mass like this. So the most common in very old patient is a sigmoid volvulus, and there is no history of any malignancy here, loss of weight or something like this. Okay. I think scenario is easy here. And you'll find no air fluid level in any other left-sided mass except in this scenario. Okay. Okay, sorry, I just 1 minute, I'll do an urgent call. I'll stop. Okay, back. Dr. Narango.
A 56-year-old lady is investigated with a colonoscopy for a change in bowel habit. However, due to adhesions from a previous hysterectomy, she experiences pain and requests the procedure be terminated. The endoscopist feels that he reached the splenic flexure. What is the best course of action? A. Discharge the patient. B. Arrange an abdominal CT scan. C. A CT colonoscopy. D. Arrange a barium enema. E. Arrange a gastrographene enema.
Very common question in recalls.
Yes.
Very common questions in recall. And very easy question, by the way. All of them, they are telling you an answer in the answer chat, in the chat.
I should cheat a little bit.
April 2018, April 2019, and expected to be in April 2020.
A CT colonoscopy because I cheated.
Exactly. Failed, yes. Okay, no problem. Failed colonoscopy, go for CT colonoscopy. Very common question in the exams. Okay, it came in 2018 recalls and in 2019 as well. Okay, patient, you are going, please, someone is just writing, please stop Okay. So patient and failed to complete the colonoscopy, you go for arrange for a CT colonoscopy. Okay. Just know it like this. And in the exam, you'll go direct for CT colonoscopy, and you will not find CT colonoscopy in any other answer as well. Okay, this is unique for this question. I don't know. This is called CT colonoscopy. Okay. Okay, next question. Doctor,
73-year-old lady presents with large bowel obstruction. On examination, she has rectal cancer, 6 centimeters from the anal verge, which has occluded the colon lumen. An abdominal X-ray showed cecal diameter 7 centimeters. Which of the management strategies outlined below is the most appropriate? D. Abdominal perineal resection of colon and rectum.
Okay, read the scenario again. This is 73-year-old lady
So
with
obstruction, sorry,
obstruction.
loop colostomy.
We'll
Yes.
go for rectal
Loop colostomy.
cancer. Rectal cancer.
Mhm.
Okay, with very large occluded colonic lumen and abdominal X-ray, cecal diameter. Okay, which of the management did he do MRI or staging?
No.
So we will go for
B. Loop colostomy.
B. Loop colostomy. Relief. Construction of loop ileostomy? No. We will not relieve the colonic obstruction. Venting cecostomy? No. Abdominal perineal? No. We didn't completely diagnose the patient. Low anterior resection and loop ileostomy? No. Also, with no operation before MRI staging.
Okay.
Okay. So we go for loop colostomy. I think it's clear now.
Yes.
Obstruction. Obstruction, that rectal mass, relieve. Obstruction, that left colon or sigmoid, remove and make endocolectomy. Obstruction on the right side, right hemicolectomy
and
extended
anastomosis.
means remove and anastomosis. Okay? Many scenario will face now. Next question, Dr. Dafir.
Okay. A 21-year-old man presented with a 5-week history of painful bright red bleeding, as the typical occur post-defecation is noted in the toilet paper. External inspection of the anal canal show a small skin tag at the 6 o'clock position. The patient decline internal palpitation. What is the most likely underlying diagnosis? Exactly, it is fissure in anal. Fistula in anal. Okay, this is fissure.
Okay, young patient.
Painful.
Short history of painful, bright, painful, bright red bleeding, typically, and after defecation or with defecation. Skin tag of the sentinel pile of the fissure at 6 o'clock, and the patient declined internal palpation. What is the most likely underlying diagnosis? This is a typical history of fissure in anal. This is the only thing here will give you a painful bleeding. Okay. Next question, Dr. Nuran.
A 66-year-old man is admitted as an emergency with torrential rectal bleeding. Following resuscitation, an upper GI endoscopy is undertaken and it is normal. However, he continues to bleed. What is the most appropriate course of action? A. Arrange a CT angiogram. B. Arrange a laparotomy and subtotal colectomy. C. Undertake a colonoscopy. D. Perform a laparoscopy and on-table colonoscopy. E. Arrange a capsule endoscopy. I'm gonna go with colonoscopy. Arrange laparotomy, subtotal. Undertake a colonoscopy. I'm going with C. Undertake a colonoscopy.
with bleeding, you just applying what you do in upper GI and the lower GI. But it is not logic to do. In the upper GI bleeding, the blood will go down, so you can go with the endoscope and you can see the source of bleeding, because with gravity it will go down. But in case of bleeding, chronic bleeding or rectal bleeding, as you go with the colonoscopy, the camera will be covered with blood, so you will see nothing, and it is unlogic to go. So choose another answer.
I'm a bit torn between doing something investigatory or something therapeutic and like a laparotomy.
Investigation. How you'll do a laparotomy for bleeding? Did you finish your diagnosis and do laparotomy for what?
No.
You will search with, you can't see with the endoscope, you will see with your eyes where is the bleeding. How can you see where is the bleeding?
I was thinking that maybe as a, well, it's a bit extreme, but to stop the bleeding, to just do a colectomy or something.
With?
Any vague bleeding, what shall we do?
A CT angiogram?
Yes.
CT angio, exactly, CT angio. Okay, so we have unknown bleeding, unknown source of bleeding here. So what we are going to do, we did upper endoscopy. We should do lower endoscopy if the bleeding is minimum, but it is still bleeding and massive bleeding, so we can't do endoscopy. So we'll go for CT angio, okay. Arrange a laparotomy, no, I can't do a laparotomy for just a bleeding. What will I do? So I remove all the intestine, undertake a colonoscopy, not logic. Perform a laparoscopy, the same like laparotomy. Sorry?
It's very straightforward. Just do a CT
Yes.
angio, right?
Okay, arrange a capsule endoscopy. No endoscopy, no laparoscopy, no laparotomy. Okay, so CT angio to detect. So sometimes it is therapeutic, by the way, and do embolization of the bleeding vessel. By selective embolization of the bleeding vessel can be done by the angio, by the way.
Yes.
Okay, next question, Dr. Abu Yazid.
55-year-old man is found to have anal cancer. His staging investigation show no mets. What's the most appropriate treatment? Radical abdominal perineal excision with anus and rectum, radical chemotherapy, excision proctectomy, external beam radiation alone, chemotherapy. I will go with A.
You are right. Sometimes some surgeons go for this, but from the UK point of view, that anal cancer, you go for radical chemoradiotherapy. All anal cancers, okay, with no metastasis, you go for radical chemoradiotherapy. This is the standard treatment for anal cancer in UK. We did see in Egypt many times that anal cancer prepares the patient direct for abdominal perineal. I know this in Egypt.
In the last session, in the upper GI, GIT, we said two end. You should remember two end. Esophagus, it is treated by the radiotherapy, chemoradiotherapy, and the anal, it's treated by the radial.
This is a standard treatment for squamous cell carcinoma.
Yes. So don't miss this. But two ends. Remember two ends.
Squamous cell carcinoma of the start or the end of the GIT, you are not doing an operation, you go for combined or radical chemoradiotherapy. Okay, good collection, Dr. Daf.
Thank you very much.
Is it clear?
Yes.
Okay, next one, Dr. Zafir.
Yes, a 62 years old man has previously undergone left hemicolectomy for carcinoma. For carcinoma, yes, don't worry. Okay. a 62 years old man previously undergone the left hemicolectomy for carcinoma of the descending colon. On the follow-up image, is found to have 2 deposit metastases located in the right lobe of the liver. What is the best treatment strategy? Chemotherapy alone, chemotherapy, follow surgical resection, radiofrequency, chemotherapy, and palliative. So it is in the chemotherapy followed by surgical. It's located in the right lobe of the liver. So I will go with the chemotherapy followed by surgical resection.
Exactly. Okay. Here is in the cancer colon metastasis. If the metastasis is only in the liver and it is, we can say, reachable like 2 or 3 metastases, you can go for radiotherapy followed by resection of these mets because it gives a high survival rate than leaving these mets.
Can I give
Okay.
points?
Yes.
It is any tumor metastasis to the liver, from the esophagus, from the stomach, from the pancreas, palliative, except the colorectal, you can do it. Remove.
Yes, this is termed non-curable.
Yes.
If there is metastasis, except for the colon, you can go for chemotherapy followed by removal of these mets.
Because the same question in the pancreas and also in the upper GI.
In the upper GI, we said this is non-curable and go for palliative treatment.
Yes.
Okay. Next question. Dr. Nurhan.
A 55-year-old man presents with tenesmus and rectal bleeding. On examination, he has a large bulky rectal cancer at 5 cm with tethering to the prostate gland. Imaging shows no distant disease. What is the most appropriate initial treatment modality? A. Abdominoperineal resection of the colon and rectum. B. Pelvic exentration. C. Abdominoperineal excision of the colon and rectum with prostatectomy. D. Long course chemoradiotherapy. E. Short course radiotherapy. For instance, rectal cancer with tethering to the prostate. Well, rectal cancer, but he already did the imaging, and so he's done his staging. But initial treatment modality?
Is he obstructed?
No, he's not. He's not. No. Abdominal concentration. Is pelvic exentration something like a laparotomy and finding out what's going on or something like that?
No. He will not give you any strange answer. Forget about it and go for the more direct, straight answers. By the way, if you find sometimes he don't find any answer.
We mentioned that abdominoperineal resection is done with cancer, so I'm gonna go between A and C. Abdominoperineal. I'll go with C.
Okay. Don't go for. Why you go for operations here?
I don't know. I honestly don't know.
Okay. So this is a 55 person. Tenesmus rectal bleeding. He's not obstructed. This is not urgent treatment. On examination, large, bulky rectal cancer, 5 centimeters from the, and tethering the prostate gland. He didn't say that he did an MRI. Okay, imaging shows no distant metastasis. You don't know what is the image. Okay, what is the most appropriate? Okay, here is a bulky cancer in the pelvis. If you went for an operation, it will be very difficult operation. It will be a horrible operation for the surgeon. What we do here, we try to decrease the size of the mass and try to down staging this cancer so we can go for the different treatment, even it is palliative or abdominoperineal resection. So, but we have to decrease the bulk of this patient, of this tumor with chemoradiotherapy. Chemoradiotherapy first, decrease the bulk of the rectal cancer, followed by the definite treatment. Okay, the margins here are like the rectal cancer is threatened resection margin. With threatened resection margins are managed with radiotherapy and chemotherapy initially. Chronic are usually primary sector. Okay.
So for this, it is a tethering. It means metastasis to the prostate. This is the first one. And the other one, the abdominoperineal, it means remove the lower anal canal and upper rectum. So in this situation here,
Exactly.
Yeah,
Here there is direct extension and infiltration of the prostate. You have first to go for long course chemoradiotherapy. May you go for debulking surgery or not? This depends after the result of the chemoradiotherapy. Okay.
So is it for all colorectal? For all? No. It's just
No.
rectal.
If rectal tumor and it is well circumscribed or small and not extended beyond the wall, you can go for definite treatment by abdominal perineal, and this is depends on the distance between the inner verge and the tumor. If it is more than 8 to 10 centimeter, you can go for
AP resection.
Sorry.
AP resection.
AP resection, high resection.
Yes.
No, AP resection if less than 8 centimeter. If less than 8 centimeter from the anus, from the inner verge, you can't preserve the anus, and you go for abdominal perineal. If it is higher than, before they said 10 centimeter, now they said 8 because of the circular stapler. They can preserve the anus because they go about 5 centimeter below the cancer and go for stapling and cut the tumor with stapling. Okay, so if it is distance more than 8 to 10 centimeters, they can go for low anterior resection. If it is less than this, we will not face any question, by the way, about this, but this is just for your information. Okay, we have, this is rectum, and this is the anal canal. Okay, and maybe this is a 10 centimeter. If we have the tumor here, we can't preserve the anus and we go for abdominal perineal. Okay, if we have the tumor here, okay, we can go for low anterior resection through abdominal, and we just go for 5 centimeter below the tumor and remove only this, and we can preserve the anus for ilioanal pouch anastomosis, or ilioanal anastomosis, or ileal pouch anal anastomosis. Okay.
Okay.
Just for information, we will not face any question talking about the distance between the tumor and the inner verge.
Okay.
Next question.
A 21-year-old female present with a 24-hour history of increasing severe anorectal pain. On examination, she is febrile and skin surrounding the anus looks normal. She didn't tolerate an attempt digital rectal examination. What's the most likely diagnosis? So anal pain with fever, I would go with E, intersphincteric abscess.
Yes.
Perfect. Perfect, yes, because you started with pain, I think you're just going to fissure in anal. Okay, pain, young patient pain with blood, so it is fissure in anal. Young patient with blood painless, mostly will be hemorrhoids. Young patient with pain and fever, it is an perianal abscess or intersphincteric. Maybe in the exam he will give it like perianal abscess or intersphincteric abscess, and this is the most common abscess in the around the anus. Okay, and the most common fistula as well is the intersphincteric fistula. Okay, if the patient has an anal pain and he didn't tell fever or blood, and you did all the investigation with your examination and endoscopy and find no problems,
Ulcer.
that's what's called proctalgia fugax. Okay, this is some neurogenic pain, by the way, from pelvic nerves, I think so, some neuropathic pain. Proctalgia fugax. This is the patient have pain and his young age, and you find no cause, you found no definite diagnosis for the patient, and you did all your investigation, ultrasound, may CT, may endoscopy, and you found everything is normal. So this is what is called proctalgia fugax. Okay?
Okay.
So this is an intersphincteric abscess. Next question, Dr. Dafer.
22 years old, presented with a 6-day history of passage of bloody diarrhea with passage of mucus and slime. He is passing an average 8 to 9 bowel movement per day. On digital rectal examination, there is no desecrated abnormality to feel, but there is some blood-stained mucus on your gloves. What is the most likely diagnosis? Solitary rectal syndrome, ulcerative colitis, inflammatory bowel disease, rectal cancer, diverticulitis. So it is young age, 6 days passage, solitary mucus and slime. So irritable bowel, C. It is either C or ulcerative colitis. Ulcerative colitis.
Yes.
This is inflammatory bowel disease.
Yes, inflammatory bowel disease, C.
Okay. It is not solitary rectal ulcer because it is not bleeding only. This is bloody diarrhea with mucus. So this is a typical picture of inflammatory bowel disease. It is not irritable bowel because irritable bowel will come with diarrhea and constipation and will not have any slime or blood. Rectal cancer is not in this age, and this is not the presentation. Diverticulitis is not in this age, and the pain will be left iliac and will be dark blood. Okay, old age and dark blood will be diverticulitis. Here, this is an inflammatory bowel disease, typical picture of inflammatory bowel disease. Okay, motions, mini motions, blood, diarrhea, mucus. Equals ulcerative colitis or Crohn's disease, but this mostly was ulcerative colitis. Next question. Imran.
A 70-year-old female is admitted with a history of passing brown-colored urine and abdominal distension. Clinically, she has features of large bowel obstruction with central abdominal tenderness. She is maximally tender in the left iliac fossa. There is no evidence of hemodynamic instability. What is the most appropriate investigation? A. Cystogram. B. Abdominal X-ray of the kidney, ureters, and bladder. C. Computerized tomogram of the abdomen and pelvis. D. Flexible sphygmoidoscopy. E. Barium enema. Brown colored urine and abdominal distension. Large bowel obstruction. Central abdominal tender, maximally tender in the left iliac fossa. Okay, brown colored urine, abdominal distension. Okay, first of all, she's obstructed.
Sync. Okay, sync with loud voice. Okay.
She's obstructed.
What do you think about? Let's take one second. Okay. Let's talk about what is the passing brown colored urine.
Stool.
Either between fistula or
Yes.
Infection.
Fistula. So it may be stool. How we didn't? This is maybe fistula stool. Killing, she had features of large bowel obstruction. Okay, maximum tender on the right iliac fossa. So she has a problem with GIT, with large bowel obstruction, together with a passing genitourinary. So most commonly brown colored. He didn't tell you dark colored blood. It is brown colored urine. So there is stool. So there is a colovesical fistula in old age. Okay, she has maximum tender on the left iliac fossa. What is your differential diagnosis about pain in the left iliac fossa
sigmoid
for an
volvulus.
old patient? Sigmoid volvulus will be obstructed. Okay, she has a large bowel obstruction with central abdominal tenderness. She is maximal tender on the right side. Okay, in the left iliac fossa, sigmoid volvulus will give you a soft, dewy mass, like our previous scenario.
Okay.
Okay, but there is tenderness in the left iliac fossa. Old age female in the left iliac fossa pain, even in part B, most commonly have a big station about diverticulitis. Okay, and diverticulitis, one or two of the most common complications is fistula formation, perforation, fistula formation, mass formation, and obstruction. Okay, stricture, obstruction of the colon. So here the scenario comes with, okay, maybe I'm saying maybe it is, maybe I'm saying most commonly it is diverticulitis, but it may be a tumor, maybe, why not tumor in the rectum or sigmoid or any part of the lower colon and perforating or directly invading the bladder and making a fistula with the bladder. So now I have two differential diagnoses, diverticulitis and how can I know? Can I know it by cystogram?
No.
Can I know it by abdominal X-ray?
No.
Can I know it by sigmoidoscopy in a patient obstructed?
Sigmoidoscopy in an obstructed patient? No.
I can't go patient obstructed from that. I go for the endoscopy and inflate and insufflate air. So the patient will rupture on table. Okay, will be perforated. Barium enema?
No. But can it be therapeutic?
You know, if it is gastrographene enema, we may think about, but he just intended to write it barium enema because contraindicate in patient obstruct or contraindicate if you doubt a fistula. Okay, so I'll do CT or MRI for the patient. Toxic,
Okay.
yes, exactly, Dr. Az. I'll do CT or MRI for the patient. CT pelvis, CT abdomen and pelvis, and the CT will delineate for me if there is fistula, the bladder and the mass, and if there is pelvic abscess, what is the extension of the disease. I'll do everything. So here I'll go for a further investigation, which will delineate for me the two problems, the bladder and the rectum or sigmoid mass. Okay, I doubt maybe through the CT we can go for cancer or we can go for diverticular disease. Okay.
Yes.
Clear?
Yes.
Okay. Okay, probably Yazid.
24-year-old man is identified as having a 5 centimeter carcinoid tumor of the appendix. Imaging and diagnostic workup doesn't demonstrate any distant disease. What's the best course of action? B. Right hemicolectomy.
Exactly. Big mass like 5 centimeter carcinoid tumor, I'll go for right hemicolectomy. Okay, but after I make sure that there is no distant metastasis or distant disease feature, so I'll go for right hemicolectomy. If it is small, less than 2 centimeters,
Yes.
and at the tip, I just go for appendectomy alone. Okay, I don't need to go for right hemicolectomy. Small, less than 2 centimeters, or at the tip of the appendix, you can remove it with the appendix without any complication. Okay, next question. Third offer.
Which of the following statement is related to the fistula in ano and true? High fistula are safely treated with the acetone insertion. Low fistula may be led.
Answer while you are telling the answer. This is right or wrong?
Right.
High fistula is safest treated with acetone.
Yes, it's right.
Yes.
Low fistula, it's yes.
Yes.
Are typically a probe with the, I don't know. Local memory probes, yes. When discovered during incision and drain of a pre-anal abscess, should always probe to
locate the internal opening.
No, this is wrong. When the complicated chronic disease may respond to the infliximab. Yes.
Okay. So the only wrong answer, when you go for a perianal abscess and you drain it, don't manipulate, don't put a probe because you are spreading infections throughout the rectum. Never ever try to cannulate or try to probe an abscess to know if there is internal opening of this. Abscess is drained outside. If you try to manipulate with a probe, you will spread infection to the inner of the rectum and the inner abdomen, and you may make perforation in the inner canal or in the rectum itself. Next question. Okay.
A 19-year-old lady has a long-standing history of diarrhea and weight loss. She is investigated with an upper gastrointestinal endoscopy, which is normal. A smooth bowel contrast study shows a terminal ileal stricture. A colonoscopy was performed, which was normal, but the endoscopist was unable to intubate the terminal ileum. 1 week after the colonoscopy, she's admitted with small bowel obstruction. Steroids are administered, but despite this, she fails to improve. What is the most appropriate treatment? A. Administration of steroids at increased dose. B. Right hemicolectomy. C. Small bowel resection. D. Subtotal colectomy. E. Panproctocolectomy. Terminal ileal stricture. Terminal ileal structure. Either right hemicolectomy or small bowel resection because it's terminal ileum. So
terminal ileum, you can do a small bowel resection for terminal ileum.
Then B, right hemicolectomy.
Exactly. Okay, so this is a patient, 19 young age, terminal ileitis or Crohn's disease, not responding to medical treatment, and she is obstructed. What will you do? Small bowel resection, no. Administration of more steroid, he told you not responding. Subtotal colectomy. Why subtotal colectomy for terminal? So only thing you'll go for ileocecal or terminal ileum problem or surgical problem, you go for right hemicolectomy. Okay. To panproctocolectomy, no, just a terminal ileitis. So you go for right hemicolectomy. Just the standard for any ileal problem, terminal ileum problem. Okay, and he told you that he can't cannulate the ileocecal valve. That means this is the swelling and the obstruction or the thickening of the terminal ileum is already reached for the ileocecal valve, so you can't do just a segmentectomy or partial resection of the small bowel. You have to go for right hemicolectomy. Okay, next question.
78-year-old lady is admitted with a 3-hour history of passage of dark red blood via rectum. Prior to this event, she was otherwise well, with no major medical comorbidity. On examination, she has a mild tachycardia, but other vital signs are normal. Abdomen is soft and no tender. Digital rectal examination revealed dark blood, but no other finding. What is the most likely underlying cause? It's A, diverticular disease.
Exactly. Old age, dark red blood rectum. Yeah, you'll find all scenarios with dark red blood will be related to diverticular disease. Okay, so no major comorbidities means that he wants to exclude cancer from your mind. Okay. She has a mild tachycardia with other vitals because of the diverticulitis itself, or the diverticular disease may make some sort of infection, but according to each staging, so it is still no perforation, no pericolic abscess. This rectal examination, just some blood, so it is only a diverticular disease. Okay, just a diverticular disease in old age. Diverticular disease is the commonest cause of lower GIT bleeding in adult, and most commonly will be dark blood. Next question.
A 75-year-old man admitted with a large bowel obstruction, and investigation is found to have a significant sigmoid diverticular structure. Underlying cause, what is the most appropriate treatment? Colonoscope and pneumatic dilatation. Don't dilate it, no. Laparotomy or Hartmut procedure. Colonoscopic is self-expand metal stent, loop ileostomy, laparotomy, sigmoidectomy, and colorectal anastomosis. So we do the self-expand metal stents.
Stent.
Yes.
For diverticular disease?
No.
So this is the left side obstruction, benign, benign left-sided obstruction. What will you do for?
Dilatation.
What's our protocol? What's our protocol for obstructed left-sided or sigmoid?
Laparotomy, sigmoidostomy, and colorectal anastomosis.
We make anastomosis on the left side?
No. Loop ileostomy
Okay.
is just either Hartmut procedure or
Hartmann, laparotomy and Hartmann.
Yes.
Okay. Do colonoscopy? No. Pneumatic dilatation? No. Colonoscopy and insertion of surface expanding stent? No. This friable part of the colon, which with the diverticular disease, so perforation is very common. Loop ileostomy, no, I didn't relieve the obstruction. Laparotomy, sigmoid colectomy, and colorectal anastomosis, no. It is laparotomy, sigmoid colectomy, and Hartmann. Okay, and Hartmann includes both of the operation, which means the removal of the structure cause or the structure segment, and close the stump with Hartmann and endocolostomy. This is the mean of Hartmann's, by the way. Okay, this is stump closed and endocolostomy. So it is laparotomy and endocolostomy. Is it clear? Read the scenario again. Large bowel obstruction, significant sigmoid diverticular stricture. So it is stricture or cancer. Okay. Watch what I will do for an obstructed patient. I want to remove the obstruction.
Yes, yes.
Okay.
Okay.
Clear? I think it is not out of our protocol.
Yes, yes.
Right.
Yes.
We make anastomosis, left and sigmoid. We remove and make endocolostomy and Hartmann. And the rectum, we just for relieve with loop colostomy. Okay, clear for all?
Here.
Okay, next question.
A 19-year-old male presents with bright red rectal bleeding that occurs post-defecation onto the paper and into the pan. Apart from constipation, his bowel habit is normal. Digital rectal examination is normal. What is the most likely cause? A.
Is
Hemorrhoidal.
painless or painful bleeding?
He didn't mention. So painless.
Yes, exactly. Digital rectal
Also,
examination is normal. By the way, any painful anal please or rectal please, patient can't withstand digital rectal examination. Can't withstand digital rectal. So it is painless rectal bleeding. Okay.
Imagining into the pan means it's of high volume, and so it suggests hemorrhoidal bleeding or something.
Yes, exactly. This fissure in anal, no, it is painful. Solitary rectal ulcer also will be painful and will be bright blood with defecation, but will be some pain. And with digital rectal examination, the ulcer will be felt. So he told you with digital rectal examination is normal. Rectal cancer, you can feel it by digital rectal examination, and this is a young boy, and this is not the typical picture of rectal cancer. Crohn's disease will not come with rectal bleeding, will not come with bright red bleeding. Crohn's disease will not come with this picture, will come with diarrhea, with mucus, loss of weight, and other scenarios then, and sometimes bright in eye, and not the rectal bleeding. The only painless rectal bleeding in a young patient is hemorrhoidal disease. Okay. Then Dr. عز. Dr. عز, no, Dr. عز, تفضل. You want to ask about it?
Okay. No, I can read if you want to share.
Okay, go. Yes. I think you want to ask, okay, it's you and then Dr. Abu Yazid. Okay. Sorry, Dr. Abu Yazid, Dr. عز will just
لا طبعا
participate.
اتفضل.
Okay, تفضل.
What is the most likely explanation for a 63-year-old male to complain of a painless blood-stained mucous rectal discharge 6 months following a Hartmann procedure? Pelvic abscess, Crohn's disease, dysplasia of the rectal stump, divergent proctitis, fissure in anal. The dysplasia of the rectal stump.
No.
Or divergent in mucus, blood-stained mucus, divergent proctitis.
Okay. Yes, by the way, this is also, it's a very common question. I think it came for me in my exam in 2019 April. Okay. This is the only answer. Divergent proctitis is the unique question with this answer. You will not find this answer in any other question, by the way. This is just 6 months painless blood-stained mucus after Hartmann. This will be inflammation or infection of the rectal stump, which is the Hartmann procedure, will be manifested by painless blood-stained mucus. Okay, unique question will have no other question the same or with the same.
But skin pain in an inflammatory stump like this, making discharge. No pain.
Just proctitis, just inflammation, just no pain. Okay. The blood will come with no pain, just a proctitis. Okay. Maybe there is mild abdominal pain that will be something like parasympathetic or vagal pain. He is talking about pain when he tell you painful bleeding. He's talking about somatic pain, like fissure in anus and something like this. Okay, but just discomfort or abdominal discomfort, like an appendicitis or diverticular disease. Okay, it will be something like divergent proctitis. Okay, just know this question like this. No other questions are the same or mimic this question. Divergent proctitis, painless, blood-stained mucus. Okay.
Yes.
Dr. Yazid, تفضل.
48-year-old lady has previously undergone sigmoid colectomy for carcinoma. On follow-up imaging, she is found to have 3 cm foci of metastatic disease in segment 4 of the liver. What is the most appropriate course of action? We mentioned that before, chemotherapy followed
Yes.
by surgical resection.
Exactly. Okay. Static small foci in the liver. 1, 2, 3. You can go for chemotherapy followed by surgical resection of the mouth. Okay.
Yes.
تفضل.
A 19-year-old man presented with diarrhea and rectal bleeding that he has been presented for past 2 weeks. In addition, he has noticed that he has a fecal incontinence at the night. What is the most likely diagnosis? Viral gastroenteritis, inflammatory bowel disease, intersphincter abscess, irritable bowel disease, and hemorrhoid, irritable bowel syndrome, and fissure in the anus. It's an inflammatory bowel disease.
Exactly.
Right.
Inflammatory bowel disease, especially Crohn's disease, the patient have some pruritus in eye from inflammation and sometimes
Fecal incontinence.
yes, no, not fecal, but sometimes leakage of fluid stool or fluid from the stool makes this patient. And if you face a patient with ulcerative colitis or Crohn's disease, he will tell you, "I'll always soak my pants," so he have to wear pad or sometimes put a piece of cotton or towel to protect against this from the pruritus and from the inflammation of the anal canal. Okay, so this is inflammatory bowel disease. Viral gastroenteritis, no. Intersphincteric abscess, no, will not come with incontinence. Irritable bowel disease, irritable bowel syndrome will not come with fecal incontinence. So it is inflammatory bowel disease, okay? Next question.
A 63-year-old man presents with episodic rectal bleeding. The blood tends to be dark in color and may be mixed with stool. His bowel habit has been erratic since an abdominal aortic aneurysm repair 6 weeks previously. What is the most likely cause? A. Ischemic colitis, B. Diverticulitis, C. Angioplasia, D. Cancer, E. Ulcerative colitis. Okay, we mentioned that in old age, rectal bleeding, dark in color, this is diverticular disease, but the thing about abdominal aortic aneurysm repair, ischemic colitis. Okay, I'm between A and B. A for the abdominal aortic aneurysm history.
What is the significance of mentioning abdominal aortic aneurysm repair in patient?
Ligation present recurrence.
Vascular compromise.
Exactly, there is a vascular problem here, and I think we have many scenarios in vascular section about this. The patient have abdominal aortic aneurysm repair followed by rectal bleeding. So what was its diagnosis or his diagnosis?
Okay, ischemic colitis.
Ischemic colitis, exactly. This is a patient rectal bleeding, sometimes dark, means that is a little bit higher in color, maybe mixed with stool, and his bowel habits. Mixed with stool means it is high, it is not low blood, it is not sigmoidal or rectal bleeding. His bowel has been erratic since an abdominal aortic aneurysm repair 6 weeks ago. Okay, this means some sort of ischemia happened, and the patient start to have complete ischemia and start to have bloody stool from the large bowel, ischemia or ischemic colitis. Okay, this is a repeated question from the vascular section, by the way. As he mentioned, abdominal aortic aneurysm. Put in your mind always ischemic colitis, and sometimes what's about loss of erection. Okay, and anterior spinal cord syndrome. This is the main 3 complications of abdominal aortic aneurysm repair. Okay, clear?
Again, ischemic colitis anterior spinal.
Abdominal aortic aneurysm repair. Ischemic colitis, impotence. Okay, the blood vessels going to the splanchnic plexus. Third is the anterior spinal cord syndrome, which may cause weakness or paralysis of both lower limbs. Anyone know the name of the artery that supplies that is obstructed or disturbed in this repair that may cause the anterior spinal canal syndrome, the anterior spinal cord syndrome?
Number?
Name of the artery?
Number artery.
It's
inferior spinal artery.
no.
Very common in recalls. Very common in recalls.
Yes.
Adam's quick.
Adam's quick.
Yes.
Adam's quick. Is something like chick name. Like I can't remember the spelling exactly, but it's
Is this
something
a
like
branch of abdominal aorta?
yes, it is a small branch from the abdominal aorta about an T12, L1, L2, and it is giving supply for the anterior spinal artery, and it is disturbed in abdominal aortic aneurysm repair. Adams quick study, something like this. Okay. So I think this is a spelling, something like Adam's quick artery. Very common in recalls, by the way.
The anatomy?
About, yes. Anatomy and neurosurgery and trauma and in vascular. But sorry, this is more in vascular, by the way. By the way, you will find in recalls many questions is not mentioned in eMRCS. That's why I always tell, I'm always confirm, I'm always pressing on recalls have more than 40% of your study, and you have to revise the recalls at least twice. Okay.
Okay.
If you yani, I remember one of my friends in January exam, and before the exam by 10 days, he told me I finished 2 times eMRCS and I'm going for the 3rd time. Is any more thing I have to study? I told him only recalls and Fawzia sheet the last 10 days, and he don't like. He told me no, I'll not study recalls, I'll just go for eMRCS again to fix it. I told him Fawzia sheet and recalls 2 or 3 times, and he just did what I told him, and after the exam he just called me and tell me about 30 to 35% of the exam is from recalls. And this question, most of them doesn't mention in eMRCS or in past test or any other source of studying. And by the way, he passed, alhamdulillah, and just he passed by 2 or 3 marks. He just about 72 or 73%. And he told me, without recalls, I will not pass.
Mm-hmm.
Okay? Put in your mind, the recalls as very, very important. Many questions and recalls are not, and it is repeated by itself, by name, by the same choices and by the same numbers. Clear?
Yeah.
Okay. We will go for recalls, inshallah.
Inshallah.
Okay. Next question.
Dr. Aziz.
Therese. Unmute. Okay.
What is the commonest type of fistula in ano? Intrasphincteric.
Yes, I said it. It's the most common abscess and the most common fistula. This is important, by the way.
Mm-hmm.
The good cells rule of fistula. We will face 1 or 2 questions. I didn't see it in recalls, by the way, but I just want to mention it. Within 3 centimeters of the anal verge, if you find the external opening of an fistula, okay, and if you want to examine the patient by digital rectal examination to know where is the internal opening, okay, this is applied only for any fistula or any external opening within 3 centimeters of the anal verge, okay. You go by digital rectal examination as follow. Above, I will take a transverse line from 3 o'clock to 9 o'clock. The patient is in his back. Consider the patient is examined while lying on his back. So from 3 o'clock to 9 o'clock, you'll take a transverse line. Any fistula or any external opening above this line, you will go with a direct line or a straight line to the opposite part inside the anal canal, and you will find the internal opening. If you find the opening below this line or from 3 to 9 below this line, the internal opening will mostly be in the midline posterior. Is it clear?
Yes.
Okay. Here is the external opening. You'll find it here. External opening, you'll go here. External opening, you'll go here. External opening, you'll go here. Okay, but in the below 1, all the internal opening will be in the midline. Clear?
Yes.
Okay. Next question.
33-year-old lady is admitted with recurrent discharging fistula in ano. She is also known to have anorectal Crohn's disease. On examination, she is found to have low anal fistula with involvement of very small amount of external anal sphincter muscle. What is the most appropriate course of action? So it's Crohn's. So I will go with A, insertion of low cetone.
Okay. Exactly. In fistula, in ano, in a patient with Crohn's disease, we go for, she's also known to have anorectal Crohn's disease. On examinations, you have a low anal fistula. The traditional treatment for low anal fistula, that you lay it open, okay? Yeah, no, not hysterectomy. You just lay open the tract and keep it open, and you just make curettage or cleaning or deroofing of the fistula. In high fistula, It is normal to go for ceton. Okay.
Okay.
Here is you have a low fistula in a patient with Crohn's disease. It is better to go for a ceton, a low ceton. You don't go for lay down the tract or fistulotomy, not fistulectomy, fistulotomy. You go for a ceton, a low ceton for treatment of a low anal fistula in a patient with Crohn's disease or anorectal Crohn's disease. Okay.
Okay.
Next question. Doctor. Okay, Dr. B, I want to ask for just a second, please. Okay.
I don't want to ask a question. I want to read if there is allowed to participate.
You want to participate?
Yes.
Okay, whose turn now?
For him.
Okay, you can go for this question. Okay.
28 years old man is reviewed in the clinic. He has suffered from Crohn's disease for many years. He has recently undergone subtotal colectomy. However, he has residual Crohn's disease in the rectum, and this is the cause of ongoing symptoms. Medical therapy is provide ineffective. What is the best course of action? Abdominoperineal excision of the colon and rectum, proctectomy, Hartmann procedure, iliorectal anastomosis, formation of ilioanal pouch. My answer was maybe proctectomy because it is a remnant of the disease in the rectum.
Okay, the patient has already recently undergone a subtotal colectomy, and now he has some small residual Crohn's disease in the rectum. So the patient would go for proctectomy, yes. Okay, for Crohn's disease, it is very common to do segmental resection of the affected part. Okay, it is very common to do segmental resection. But in ulcerative colitis, the most common is proctocolectomy. Proctocolectomy is the most common operation because all the mucosa of the colon is susceptible, and doing segmental resection is not a common practice in ulcerative colitis. So here you'll go for proctectomy. Yes, exactly. Next question.
75 years old lady is admitted with a large bowel obstruction. She is previously well. She is investigated with an abdominal CT scan, and she is show an obstructed carcinoma in ascending colon. What is the best course of action? Laparotomy, reticulectomy, and ileocolic anastomosis, laparotomy, ileo and ileocolic bypass, laparotomy and loop ileostomy alone, insert stent, laparoscopic and subtotal colectomy. It is A.
Yes, that's our protocol, so?
Yes.
Yes, this is our protocol. Obstruction, okay, and the mass is in the right side, so I remove the mass and I'll go for anastomosis.
Yes.
Okay.
Yes.
Clear? Clear for all, I think so.
Yes.
Okay, next question to Nuran.
A 23-year-old man is admitted to hospital with diarrhea and severe abdominal pain. He was previously well and his illness has lasted 18 hours. What is the likely cause? A. Laxative abuse. B. Clostridium difficile infection. C. Salmonella gastroenteritis infection. D. Campylobacter jejuni infection. E. Ulcerative colitis. Previously well, lasted 18 hours. It's probably an infection. Clostridium. B.
Okay, no, it's Campylobacter. Okay, this is not common question, by the way, and this is some like infection, gastroenteritis, and microbiology questions. microbiology questions, you will just know it as it is. We'll go for some question of microbiology. This organism doing this organism doing this is the side effect, and this is the medication of this organism. Just know it as it is, okay? So, Campylobacter jejuni is most common with severe abdominal pain and diarrhea. Okay?
Okay.
Go for the next question, Dr. Nuran.
A 25-year-old male presents with altered bowel habit. He is known to have familial polyposis coli. A colonoscopy shows widespread polyps with high-grade dysplasia in a polyp removed from the rectum. What is the best course of action? A. Undertake a panproctocolectomy. B. Undertake an abdominoperineal resection of the rectum and sigmoid colon. C. Undertake a subtotal colectomy. D. Undertake a left hemicolectomy. E. Perform sequential colonoscopic polypectomies until all polyps are resected. Familial polyposis coli, widespread panproctocolectomies. There's nothing conservative in the choices.
You'll go conservative for a patient with familial polyposis coli, 25 years old.
I think it's the patient's decision, so I was thinking maybe there would be an.
And the patient represents a high-grade dysplasia.
Okay. So panproctocolectomy.
Yes, say.
Yes, yes.
Panproctocolectomy.
Panproctocolectomy. The protocol of patient with familial polyposis coli. This patient by the age of 35 to 40 will have 100% cancer colon. Okay, so the protocol is to go with, you have a family history of familial polyposis coli. This patient will go for a colonoscopy at 10 to 12 years. Okay, this is the protocol in UK. 10 years or 12 years, you'll go for colonoscopy. If you found it clear, you'll repeat it after 5 years. If you found a polyp or something like this, it depends on the number and the size. You will take the patient scheduled for serial colonoscopy survey, okay, surveillance. At the age of 25, offer the patient for complete proctocolectomy, especially if you find in your serial endoscopy, lower endoscopy in the last few years, increasing number of polyps, so go direct for panproctocolectomy. So this patient is 25 years old, altered bowel habits, have familial polyposis coli history, colonoscopy show widespread polyps, so it's a typical patient for colectomy, and with high-grade dysplasia in one polyp. So you have to remove all the polyps to do for histopathology, and it is not logic. The patient of familial polyposis coli or history of family history of FAB, okay, and represented by before the age of 25 by the complete picture of FAB, offer the patient for panproctocolectomy, because this patient within less than 10 years, he will go 100% for cancer colon. Okay? Clear this protocol?
Yes.
You will start surveillance endoscopy at the age of 10 to 12, sometimes tell you 10, sometimes tell you 12. And then if you didn't find, you go, if you repeat it after 5 years. And if you find, you will stage it and depend every 1 year, every 3 years, every 5 years. Before the age of 25, if the patient has increasing number of polyps, you'll go for panproctocolectomy. Okay? This is the new guidelines 2020, by the way. Okay? Even pathologists or endoscopists are not knowing it, and they have the table in front of their office. Okay, so you don't need to just know the questions will come. If you have the ability to understand it and to know it, it's okay, no problem. Just read it, but it's difficult to know it. Okay, and the previous one was much more difficult, by the way. and it was completely confusing table for surveillance endoscopy. Next question. I think we have last two questions now. Okay, next question. Who's there?
What is what is the most likely diagnosis in a 17-year-old man who presents with painful bright red anal rectal bleeding that has been noticed at occur in past 2 weeks? Fissure in anal.
Exactly. Young patient, painful bright red and rectal bleeding, fissure in. No other symptoms, so it is fissure in anal until proved otherwise. I think this is last question and we can continue tomorrow. Dr. أبو اليزيد تفضل.
53-year-old man is due to undergoing right hemicolectomy for cecal carcinoma, which is the following would be usual practice prior to surgery.
This is the
Or
enhanced
carbohydrate A.
Yes.
Drink 2 hours.
This is enhanced recovery protocol. Oral carbohydrate loading drink just 2 hours before preoperative, and there's very common questions asking. We have many questions. I think I did see it about 3 times in recalls, asking about what is the one of the following is a common practice for the enhanced recovery protocol, or sometimes comes like this question: right hemicolectomy, what is the following practice, the usual practice? He asking about the enhanced recovery protocol for patient, and you can see, search about it in Google and read about the enhanced recovery protocol. This is preoperative, intraoperative, postoperative precautions be done for patients to improve the outcome of your surgery. Okay?
Okay.
Okay, I think we finished. I'll stop recording.